everyone. I appreciate you joining us. We're going to have a good, brief, concise, hopefully informative discussion. I really appreciate you joining us. I'm Scott Taylor, and Dr. Andy Davison will be joining as well. I'm going to go ahead and kick it off. I just was informed, we're hot off the press, this is National Pain Awareness Month. So we are going to do a very concise, brief discussion on spine, specifically spinal stenosis, and then dovetail into a procedure that we're super excited about called Vertiflex, which has been a game changer in our practice. So having said that, hopefully everybody's on now. I would like to go ahead and move to our first slide, introduction to the prevalence of spine and arthritis resulting in spinal stenosis. So the baby boomers are hitting the circuit here. We have a picture here of a circuit of pain. 73 million baby boomers are entering this, and as you all probably know, 80 to 85% of people at some point will experience back pain. We're specifically going to look at spinal stenosis. So you can see this circle might start with a general physician or mid-level, be referred off to a pain specialist, and then possibly a surgeon. And then maybe surgery is not indicated or doesn't work, and interventional treatments. So there are 380,000 new patients added annually to this circuit. And patients are sort of on a carousel of pain looking for some relief. So if we could have the next slide, I want to make spinal stenosis is often confusing, I think, especially to patients and sometimes providers, but it's really, honestly, it's pretty simple. It's essentially what I tell patients, a crowding of the channels where the nerves pass through the spine. And it can result in misery and a lot of functional difficulties for your patients, often causing what we call a neurogenic claudication. So the picture just shows you have a disc that may degenerate or thin over time, and then you may develop some arthritis around the facet joint. And then there's a ligament in the back of the spine, the ligamentum flavum. So this can thicken or sort of buckle over time. And when this happens, the spine nerves become more crowded, and that can result in pain, tingling, numbness, weakness, and difficulty standing and walking. One of my favorite things to ask is, somebody's typically retired, maybe not, and they're sitting there in the chair. I say, how do you feel now? And they say, I feel great right here, but I didn't work my whole life to sit in this chair. I got a workshop, I want to go to the store. And if I grab a cart, or they may not say it, and I'll ask them, say, oh, yeah, I can really go when I do that. So one of the key take-homes of our talk tonight is going to be flexion, spinal flexion. And we can achieve spinal flexion by doing the old grocery cart sign, sitting down in a chair, or maybe you're in the kitchen and you lean your arms on the countertop to flex that spine open. That's a key point to this procedure. So let's have the next slide. So stenosis can be, this breaks it down into three basic types: the central, the lateral recess, and the foraminal. So the picture is a cross-section through a vertebral segment. This one's showing a disc that's herniated, pinching the nerve there. But central stenosis, you will get claudication. Actually, all three of these cause claudication. But central stenosis is where they get back pain, buttock pain, leg pain, and it's very positional. And they can possibly have weakness with it too. Now, when it's out further down the nerve off the spinal cord, it's called lateral recess, and they can get more of a radicular or sciatic pain. Now, weakness would be rare here, but it's more of a nerve shooting pain, possibly further down the leg or more localized. And then foraminal even gets out further down the chain on the nerve, and it's radicular, may follow a dermatomal pattern, burning and tingling, and it is sometimes positional. So this is, again, if you look at the slide, lack of symptom relief with flexion is exclusionary for Vertiflex. So we want to make sure these patients get relief when they lean forward. Next slide. This is a picture. Why does flexion help? The canal and foraminal space for nerves improve in flexion. And when we stand up out of a chair and you've got, say, some facet arthritis and they try to pull their shoulders back and stand up tall, groaning and holding their back because it's, loading those arthritic facet joints, then the stenosis worsens and weakness and pain and difficulty standing and walking. So, up until this procedure came to our practice about 2.5 years ago, these folks would get all the conservative things like medication, physical therapy, epidurals, and, if they work, there are a lot of folks that get by with a couple a year and they do well. But when they stop working or don't work, kind of the next step was, surgeon for a laminectomy or fusion. So what we're going to talk about today has been a game-changing innovation and practices like ours all across the country, as Dr. Davison will dive down a little more on details with. So let's go to the next slide. So the Vertiflex procedure is a titanium spacer. You can see it on the right side, the right-sided picture. It is FDA approved. We have well over 100 patients in our practice over the last 2.5 years that have had this procedure. It's about a dime-size incision at most, same-day procedure. Our patients all walk out of the hospital the day of procedure. There's no removal of bone or tissue, and it's a speedy recovery time. Low risk of infection, and there's robust data we'll get into a little bit further down the road here. And more than 10,000 patients have been treated since 2016. And the other thing this doesn't really say, it is a reversible process. So this, I'll tell the patients, this is something, if it fails, it's reversible. You still have a native spine. All the tissue and bone is still there. So they could go on to have a old school traditional surgery. Next slide. So it uses a small spacer. It's shown in this video. You'll see small incisions made, and this trocar is passed through a small tube, and the spacer is opened. We measure it off with a tolerance. There's a special tool that measures the distance and the force. And the key here is the spine is not being forced open. The spine is receiving a spacer that limits extension at that segment. So having said that, in the video, I'm going to go ahead and introduce Dr. Andy Davison.
Hi, I'm Andy Davison, and we're really excited about this procedure and all of the real-world results. So I'll go into a little bit more details about patient selection. This slide here shows a pre-op image of an MRI with significant stenosis at the L3-4 level, which you can see. And then after Vertiflex placement, it's evident that you can see more of the spine not being compressed at that level. And again, it's not jacking open the space as some people kind of think about it, so it doesn't, but it purely limits the extension, giving them that sense of sitting down even when they're up doing their activities. Next slide, please. So people often ask us, is a Vertiflex effective at, helping treat kind of chronic pain more than the opiate medications? And over a 5-year study, 85% of the patients were able to come off of opiate pain medications. And that's a big deal for our practice, as we're big believers in using interventions as opposed to pain medication to treat pain. We feel like this procedure goes and actually fixes the problem of stenosis, as opposed to a lot of our patients say, I don't want a Band-Aid. And we're glad when we can offer this procedure, because we can tell them that it's a kind of solution to their problem as opposed to a masking of the pain symptoms. Next slide, please. This is a poster that Dr. Taylor and we have in most of our exam rooms. And fortunately for us, a lot of our patients sit in the room kind of being checked in before we show up and are able to self-identify. And especially with the, the grocery shopping cart sign, we kind of ask them, do you get relief leaning on that cart? Just a little bit of flexion in the spine can often relieve the pressure on the central canal, that lateral recess, or the foramen, all those three levels where the nerves can get pinched. And that's kind of what Vertiflex aims to do, and just gives them that little bit of flexion moment to provide enough room to where they can avoid a major surgery. So a lot of the times these patients present as the ones leaned over their canes or walkers, or they prefer not to be as active as they once were because of the pain that they experience with prolonged standing or walking, standing too long at the counter, cooking meals. They say, I have to have a stool now. So these are really good kind of patient identifiers for stenosis. Next slide, please. So kind of dovetailing on that idea, the patients that are kind of stenosis buzzwords are especially pain that's in the lumbar spine that gets into the legs, that neurogenic claudication. As the longer the patient stands and walks, the more that nerve becomes compressed and the pain becomes more severe, possibly going further down the leg. And like Dr. Taylor said, it's key that they get relief with forward flexion or sitting down. We have plenty of patients that tell us, it hurts kind of all the time and it's not necessarily better sitting down. And that's kind of exclusionary, because that may be another pain generator besides stenosis. So anybody that's failed more conservative measures, epidurals, therapy, anti-inflammatories, that maybe want to avoid a major back surgery, this is often an exciting option for those patients, as it is a outpatient procedure. Typical operative time takes 20 to 30 minutes, depending on whether we do kind of one level of stenosis or two levels. Recovery time is quick. They go home that same morning of the procedure and wear a lumbar spine corset for a week or two after, as opposed to the downtime and the limited mobility and time off work that a big spine surgery requires. Next slide, please. So Vertiflex, along with Boston Scientific, their parent company, has collected real-world results that, on the next slide, you'll see match really well with the clinical data that was collected, which is always nice when your controlled data set kind of in a lab matches up with, as this procedure has been out across the country. This is the 5-year data that matches the clinical data. 9 out of 10 people are very satisfied. Again, reiterating the 85% drop in the opiate use, improvement in function, and especially reduction in back and leg symptoms. And it's a very satisfying procedure when you see patients come back, even at the 2-week mark. We follow up at 2 weeks and then 6 weeks with x-rays, and they say, I can't believe how much more function I have. My pain is significantly reduced. Being able to do things that they enjoyed doing but were limited in the past, that's kind of the satisfying part about this procedure, is that it's effective and minimally invasive. Next slide, please. And so you can see that this clinical data mirrors almost exactly the real-world data that we had in the previous slide. The patient satisfaction remains high. So that's another question that we get a lot from the patients that we offer this to is, how long is this going to last? And since it's titanium and it's a spacer, it may last them the rest of their lives. There's no reason it can't. But the nice thing about it is, God forbid, they had to have surgery in the future. Like Dr. Taylor said, it is reversible. And by not cutting out any bone with this procedure, we're just simply adding the implant. If it had to be removed, you're you haven't marred the playing field. They still have a virgin spine, so to speak, if they had to go on to surgery. Next slide, please. So as far as when do we start considering when Vertiflex may be a good idea, typically we like to do the least amount of work that allows the patient to get the most benefit. So if conservative care works over the first 6 weeks, then that's wonderful. And we don't have to move on to injections or considering Vertiflex. But kind of the things we look for is that the clinical story matches with the MRI evidence that helps us choose, what level makes most sense for placing a Vertiflex device. Medicare and most insurances, if this is approved, we can do up to 2 Vertiflex implants at a time to perhaps address L3-4 and L4-5 at the same time. And so we match up the patient's symptoms, their particular leg symptoms with the MRI. And we also sometimes get flexion extension films to make sure there's not a lot of spondylolisthesis that would make this unstable. So, Dr. Taylor and our practice is interventional driven as opposed to medication driven. And, sometimes it's difficult to say, what is the pain generator in back pain? And that's kind of where we come in to help you as referring providers to say, do a little bit more of the workup. And if it's not spinal stenosis, we do have lots of other options, including therapy and, neuropathic pain medications, anti-inflammatories. We kind of like to take the holistic approach and kind of tailor a treatment plan that suits an individual patient. We're very invested in it's not a one size fits all program. So I think that's all I have to say about that. Dr. Taylor, if you have anything to interject.
I just wanted to say our practice, Dr. Davis and I are both PM&R, physical medicine rehabilitation trained. So, our approach is very functional. So when a patient comes to see us, first time patient, and, we do a functional exam that a lot of patients will say, well, have you seen the MRI? Have you seen the x-ray? As soon as I sit down or whatever, or start talking. And, first I'm going to get a history and then do a functional examination of the spine, the hips, all the things that are important. And then somebody may say they've had physical therapy. Well, that physical therapy isn't the same, many variables, obviously, the way it can be done, what was done. So we really want to make sure, if we're building a building to help this patient with pain, we want to make sure the foundation has been set straight. Have they had good education on home exercise, biomechanics, good physical therapy, checking for a leg length discrepancy, a lot of things that can be missed going right, drilling down to a procedure. So we want to make sure the foundation's set before we get into high-tech intervention. But starting the 28th year of practice, this came about 2.5 years ago, this Vertiflex, and it's been a total game changer for my patients. It's been extremely rewarding with the results we're seeing. It's so rewarding to have a patient come back, and when they say we've changed their life, it's just been great. So we would be happy to entertain questions as far as anybody has any